Spasibo za priglašenje v Moskvu. So these are my conflicts of interest. As we have heard before from the previous speakers, we of course have one good side and one bad side of treating patients with our drugs, and we want to prevent them from having a thrombosis, but often we cause them a bleeding instead. So we have heard quite a lot about aspirin, and this is a systematic review and meta-analysis of adverse events in low-dose aspirin and clopidogrel in randomized controlled studies. And it says that low-dose aspirin increases the risk of major bleeding by 70%, but the absolute risk increase is quite modest. According to this study, 769 patients need to be treated with aspirin to cause one additional major bleeding annually. And this is a table from that study, and as you can see, the major bleeding increased by 70%, and the major gastrointestinal bleeding was doubled. This is data from the Capri study looking at bleeding events, and in the Capri study, aspirin was compared to clopidogrel. And here we have bleeding events, and it was quite similar numbers with clopidogrel and aspirin. However, the GI bleedings were more common in the aspirin group compared to the clopidogrel group. This is the landmark study, the CURE study, and these are the bleeding outcome. And again, major bleedings were more common in the combined group with clopidogrel and aspirin compared to aspirin only. And also the major bleedings were more common in this combination group, as we might expect. And if we go to the newer antiplatelet drugs, this is the famous Triton TIMI38 study, and as you are well aware of, the prasugrel is associated with an increased bleeding rate compared to clopidogrel when we look at non-CABG related TIMI major bleeding events. And the other study is the Plato study using ticagrelor. And if we look at the same thing here, non-CABG related major bleeding, according to the TIMI criteria, the bleeding events were a little bit higher in the ticagrelor group compared to the clopidogrel group. However, in the whole study, there was no difference in bleeding events. Going back to older studies, we have aspirin versus aspirin plus clopidogrel, active A study above here. And we have, as expected, more gastrointestinal bleeding events in the combination group compared to aspirin only. Looking at the table below here, we have active W study comparing dual antiplatelet treatment versus oral anticoagulation. And here we have a major hemorrhage with a risk of 2.4 in the dual antiplatelet group and 2.2 in oral anticoagulation, and that was not a significant difference. However, if we look at the total bleeding event rates, that was increased in the dual antiplatelet treatment compared to the warfarin group, and that was a significant difference. So, in summary, we have heard this before, and aspirin and major GI bleeding, we have an annual incidence of 0.4%, according to this meta-analysis, and the relative risk increase is quite significant. It's more than doubled. However, the absolute risk increase is quite modest, 0.12%, and the number needed to harm, according to this analysis, is quite high, more than 800 patients. And what about the dosing? And the first speaker was talking about that as well. And if we look at observational studies, they report conflicting results regarding risk for GI bleeding with 75 and 325 milligrams daily. But if we go above that dose, we for sure increase the gastrointestinal bleeding risk. Triple therapy, and this is quite common now, and it's estimated that 5% of patients undergoing PCI require long-term oral anticoagulation due to atrial fibrillation. This is a large Danish study looking at patients with AFib who were admitted with myocardial infarction for PCI, and it was quite a substantial number of patients, more than 11,000 patients. And complications with cardiovascular events and bleedings were registered. And here we look at when non-fatal and fatal bleeding, and if the patients were on monotherapy, aspirin, clopidogrel, or oral anticoagulation, there were 70% incidence. And if we go to dual therapy of different kinds, these figures increase. But as expected, the triple therapy is associated with doubled the risk for bleedings if we combine aspirin, clopidogrel, and anticoagulant treatment. So, and this is, we get what we pay for in life, and this is the event rate. And the event rate is highest here in those patients treated with single antiplatelet treatment, and it's lowest in patients with oral anticoagulant treatment plus one single antiplatelet therapy or triple therapy. Here is the price, bleedings, and in the triple therapy group we have, as said before, the highest bleeding event rates. And second is the oral anticoagulant treatment combined with a single antiplatelet treatment. And based on this study, the Danish study, maybe this Dutch study came up with their idea. And it's quite a busy slide, but the main point is that they compared the triple therapy treatment in patients with an indication for oral anticoagulation who underwent coronary stenting versus the combination of oral anticoagulants and clopidogrel. And as we could expect, the bleeding events were very much common in the triple therapy group compared to this double therapy group. But less expected was this observation that the mortality was higher in the triple therapy group compared to the double therapy group. So this study indicates that in some cases it might be good enough to have a double treatment instead of a triple therapy treatment. So what happens over time with triple therapy? We have most of the bleeding events when we start up the treatment during the first month. However, the cumulative annual incidence of major bleedings are steadily increasing with the treatment time. So this text is from the last NSTEMI guidelines published in European Heart Journal 2011, and it states that bleeding is a major problem in patients with acute coronary syndrome, and bleeding is associated with a poor outcome. And gastrointestinal bleeding makes up 50% of all the spontaneous bleeding events during the initial phase of acute coronary syndrome. So this is for sure a clinical problem. So what can we do about it? Can we prevent it? This is one study, the Oberon study, and they picked up patients with high risk for peptic ulcer, and they randomized them to different doses of esomeprazole or placebo. And as one might expect, the incidence of peptic ulcers were almost gone if we have esomeprazole on board compared to placebo after 6 months. What about histamine 2 inhibitors? And we have a few studies, observational studies there, but the results are not so convincing. So if we should treat patients to prevent gastrointestinal bleeding, we should use the PPIs. So this is from the guidelines of STEMI from ESC, and here the authors says that gastric protection with a PPI should be considered for the duration of dual antiplatelet treatment in patients at high risk of bleeding, and risk factors are given in the text. And this is the corresponding table from the NSTEMI guidelines, and it says basically the same time, but the recommendation is even stronger here, 1A. And also this is true when we look at the AFib guidelines from ESC. And if we go over the Atlantic Sea and look at the American guidelines, they say exactly the same. But we have a problem with clopidogrel because it has to be converted to an active metabolite with this CYP2C19 system, and the PPIs, they inhibit this enzyme. And as you are well aware of, there are different kinds of PPIs, and we have those with strong inhibition like lansoprazole, omeprazole, or esomeprazole, and we have those with weak inhibition such as pantoprazole. This is one landmark study looking at platelet reactivity index, and as you can see here, if we have omeprazole on board together with clopidogrel, we have a worse effect on platelet reactivity compared to if we have pantoprazole on board. And this is true for pre-dose and 5 days post-dosing. So according to the lab data, this is important. However, there is a study looking at clinical events, and that's the Cogent study. And what they did is to give the patients clopidogrel with or without omeprazole in coronary artery disease. And this study confirmed previous observation that the patients were protected from gastrointestinal endpoints. And what about the cardiovascular events? It was no difference between the study groups. So according to this study, it's quite okay to treat these patients with omeprazole despite this laboratory finding. However, there were some problems with this study. It was premature termination because of lack of money. They included 3,700 patients instead of a planned 5,000 patients. They found, as expected, a significant reduction of gastrointestinal event rates, but no difference in cardiovascular event rates. If we look at the new drugs, prasugrel, this is a prodrug, but it's not limited by metabolism. And ticagrelol is an active drug, so they are not involved in this interaction as clopidogrel is. They are bypassed. So our working group, together with a working group on thrombosis, published quite recently a position paper about this. And if we go to the summary directly, we confirm that no conclusive evidence to discourage PPIs with clopidogrel, but evidence of benefits in terms of bleeding reduction. Therefore, PPIs should be carefully prescribed if indicated. A PPI with less CYP2C19 inhibitor capacity, such as pantoprazole, may represent a more optimal treatment option than a PPI with a high inhibitory capacity, such as omeprazole. This is based on the lab data, not on the clinical event data. We have no evidence to discourage PPIs with the newer antiplatelet drugs, and I leave the other conclusions. So if we treat the patients with prasugrel or ticagrelor, we can choose any PPIs. If we go for clopidogrel, maybe those with less CYP2C19 inhibitor capacity should be chosen, such as pantoprazole. So in summary, bleeding risk, especially risk for gastrointestinal bleed, increases with antiplatelet therapy, and bleeding risk, bleeding risk further increases with dual antiplatelet therapy, and bleeding risk is high with the new antiplatelet drugs such as prasugrel and ticagrelor compared to clopidogrel. And risk for gastrointestinal bleed and complication is substantially reduced by PPI co-treatment. Triple therapy for AF stent in ACS is associated with the highest bleeding risk, and limited data available for triple therapy, especially for NOACs and the new antiplatelets. And current guidelines with NSTIM and STEMI and AFib recommend use of PPI with antithrombotic therapy in patients at high risk for bleeding. And then, as a chairman of the working group of cardiovascular pharmacotherapy, I want to mention our new journal, which is a journal of the European Heart Journal family, and it's launched this year, and it's available for free on the internet until next year. And of course, you are welcome to submit the paper to us. The web page is open and working fine. And this is the address of the web page, quite easily to find if you look in Google. So thank you for your attention.